Well, good morning, everybody. It's a pleasure to kick off our session this morning and give everybody an update about the clinical task force. Just to remind you all, this has been quite a lift for us. As we got started, we ran right into COVID and had to get distracted by a few things like that. But we realized the gravity of what we're doing. You know, the numbers that Bud presented yesterday for the number of participants, the number of data points is just extraordinary. And to remind you, we've really been charged with trying to balance a very difficult task of reducing burden where possible, and also recognizing the complexity, the heterogeneity of Alzheimer's disease, mixed etiology, dementias, having things like FTD, DLB, vascular, all these things that are sort of spin-offs and are supported by their own large programmatic grants like the DLB Consortium, MARC, VCID. Our job at the UDS is to make sure we can, where possible, collect consistent information. That really helps us move forward in an efficient manner that sort of informs across the spectrum of ADRD. So I just want to remind people the task force has been doing an enormous amount of activity, perhaps more quietly than everybody likes, but I think we've tried to be as transparent and inclusive, welcoming for all input that we can gain. We've been, the task force is led by the folks listed on the slide here. We're going to focus on some subgroups that have come out of the clinical measures work group this morning. We'll talk about mild behavioral impairment syndrome, a very much, I think, under-recognized area of symptomology that's so important for the whole spectrum of dementias, that we have really important opportunities to augment the data collection for. And then we're also going to hear about more the work group that's led by Lisa and Andy about subjective cognitive decline. And so mostly the hour that's coming up, we've built in mostly time for discussion, again, with the spirit that we really need input from everybody to try and thread the needle to make the measures that we're collecting as efficient as possible, but also inform, the future research that will come ahead. So really kudos to everybody on the task force that has just put an enormous amount of hours into weekly or meetings often in many cases. Also, I want to thank NAC. The support we've had from NAC has really been great. We heard all the exciting things from Sarah yesterday and Bud and others from NAC. And while they've been doing all these new things and envisioning a new platform, they've also been providing much more support for the CTF than they had in the past. So thank you guys for your terrific help and partnership and all that. So the CTF has been making progress. What you see here are 3 columns. You saw this yesterday from Sarah and Bud. The task force has done the revisions on most forms, I would say. The middle column, we're pretty much through most of these under review by the clinical task force, these different forms. We heard the great talk yesterday from Lisa about the social determinants of health. Just want to remind people that is absolutely vital. We're not making it mandatory right now. I was tempted to ask everybody yesterday if we might make it mandatory because we all believe in how important that is, and there's so much excitement about our ability to work together and collaborate, but we'll leave it optional for right now, and just encourage everybody to collect it so we can learn over the next 6 to 12 months how many centers are doing things and move more wisely as we have across the spectrum of forms that we collect. So I won't review again all the forms that are at hand. We still have quite a bit of work to do, but we're aiming to get things done by the end of this calendar year so NAC can build the forms. So let me now introduce the next session. So Howie, if you would join me. Howie Rosen, as you know from UCSF, has been leading this work group with Kostas Liketsos, who's going to join us virtually. Kostas is at Hopkins, so thank you guys. Yep, I just did.
Okay.
Kostas Liketsos, is he up? There you are. Thanks. Good morning, Kostas. Thanks for joining us.
Good morning, everybody. I'm sorry I couldn't be with you in beautiful Chicago this fall day. So Howie and I have a brief presentation. I'm going to discuss a few slides first, and then Howie will bring it home. And I think we'll have some time for questions later on. So if I could have the next slide. So the starting point of our discussion in the clinical task force has been the topic of neuropsychiatric symptoms. And we have taken this as an opportunity to do a couple of things. First is to strengthen what we do around the measurement and differentiation of neuropsychiatric symptoms, and to do an even better job before the onset of dementia, because we think that before the onset of dementia is where a lot of interesting action and a lot of interesting research can happen. So specifically, we're proposing changes that would allow us to capture neuropsych symptoms in people without dementia and in part differentiate the age of onset of these symptoms. We'd like to strengthen differentiations of DSM-5 disorders. Right now, our various forms are not as carefully constructed as they could be to differentiate symptoms from syndromes from DSM disorders. So some of the changes we're proposing are intended to do that. And then finally, as I'll show you in a couple minutes, mild behavioral impairment is emerging as a very interesting syndrome that we are proposing the ADRC should collect data about, both in terms of its occurrence and its severity. Next slide, please. So I will run through one or two slides quickly. They will be available to you, but the first point is that neuropsychiatric symptoms have been shown to be universal over time in everyone with dementia. We showed this in Cache County and in the cardiovascular health study. But I also want to point out, as you can see on the slide in the right and the highlighted box at the bottom, that about half of people with MCI have neuropsychiatric symptoms. And this is something that those of us who analyze data from the NAC also can confirm is the case in NAC. Next slide. In fact, a NAC analysis my team ran a few years back suggested that before a diagnosis of MCI or dementia, well over half of people in the NAC have neuropsychiatric symptoms. So what you see here briefly on the left side is the track of individuals. Red is observational periods in the NAC where they have a diagnosis of dementia, blue is MCI, and gray is when they do not have either diagnosis. And where you see segments or boxes with crosshatch, those are times when they have active neuropsychiatric symptoms. Basically, the point here is if you look at the gray area, which is people who don't have MCI or don't have dementia, these are all people who go on to progress, and you can just see visually how frequent the occurrence of neuropsychiatric symptoms is before either of the cognitive syndromes occurs. Next slide, please. Over many years, many have shown, I'm just giving you select data, that if you have CIND or MCI and NPS, you convert to dementia much faster than if you don't. And the same is true is if you are unimpaired, you convert to MCI or even dementia faster than if you don't. So these symptoms are appearing to be predictors of a worse cognitive progression. Next slide. This has given rise to the construct of MBI, which is trying to put together an entity we think is a behavioral syndrome that is a particularly potent predictor of poor cognitive outcomes. This was a draft criteria publication that I'm showing here. I'm not going to belabor the diagnosis of MBI, but serve to say that there is an established set of criteria that have been used in research all through the US and other areas of the world. This is a pretty reliable diagnostic entity, which we are now hoping to introduce into the Alzheimer's centers. Next slide, please. So if you have mild behavioral impairment and you have MCI, as you will see here, next bullet. Oh, I'm sorry, I thought I had a different slide here. Any rate, so the first demonstration of the effects of MBI on outcome was from a paper with Tarragano. The slide is a little bit messed up. I'm sorry. Can you advance it? Okay, so let me jump ahead. I thought a different slide was going to show up. So Tarragano, in 2 studies in Argentina, showed that amongst people referred to a memory clinic, if you had an MBI syndromic diagnosis, which is a little different, but not too much from the one we're proposing, your transition to dementia, whether it be Alzheimer's or FTD, was accelerated. And this was also in the later study, they showed that this is very different from people with lifelong psychiatric conditions. So on the slide on the left, you'll see that if you have a lifelong psychiatric disorder in this referred group, you actually don't progress to the next stage too fast. But if you have MBI, which is not a psychiatric condition of lifelong duration, you do. And this has been replicated in large MCI cohorts, that if you have MBI versus no MBI in the context of MCI, you have a 2 to 8-fold greater odds of progressing to dementia. And same is true with an SCD cohort of patients in Canada, a very substantial odds ratio, 8-fold risk if you have SCD and MBI to progress to dementia. Next slide, please. So, so that was the points I wanted to make as to what we're trying to accomplish. The main focus is MBI, but the broader picture is we also want to strengthen how we capture and measure neuropsych. So I'll turn it over to Howie.
Thanks, Costas. I'm sorry you can't be here either, but I'm glad we're able to present this together. First, I think it's helpful to review sort of how the UDS captures neuropsychiatric symptomatology as it currently is. So we do have the MPIQ and the GDS where we can capture many of these symptoms, and the B9 form, which is the one where we record individual cognitive and behavioral symptoms, captures some symptoms that fall within the psychiatric spectrum, and we can indicate that somebody has a psychiatric disorder, depression, bipolar, etc., in the latter part of the D1 form, and with the implication being that most of the time it's going to be a syndrome that we have to account for in thinking about somebody's cognitive impairment. But, you know, if behavioral symptoms are the primary emerging symptom early in the course of disease, we don't really have a place where we could, a syndrome to attach all these symptoms to right now. And also if somebody does have a psychiatric syndrome that would be found in the DSM-5, we have nowhere to indicate whether it's early onset or late onset, which has, you know, quite a lot of significance in terms of its implications for conversion to dementia. So I'm just going to go through some examples and talk about how we've revised the D1 forms to try to address these issues. You know, so take an example that I'll discuss now, similar to people I've seen in the last year, actually. So picture a 60-year-old man, let's say, who has no prior psychiatric history, and his family reports some behavioral changes over the last 3 years. In this case, he's lost interest in things he used to enjoy, going to church, being part of the men's group there, and similar things. And he's become more inappropriate in social gatherings. He'll insult people, call them names, saying they're stupid if he doesn't agree with them. And here's an example. He might have said, well, fat people won't survive after the rebellion anyway. And this particular example is bespeaks some of the interests he's developed. So I'm not making this up. He's endorsing different political ideas that weren't interesting to him in the past, including kind of survivalist ideas. He's buying a lot of equipment, tents, non-perishable foods, storing it in his basement, and almost to the point of hoarding. He's collecting these things really more than he would even need. He spends a lot of time on the internet and going to local groups about this, and he kind of, eschews family meetings, gatherings and things, which he was always a great part of in order to kind of be involved in this. He doesn't feel anxious, though. He doesn't feel depressed. There's no evidence of any delusions. He has no cognitive complaints. There's no indication of cognitive change. And his testing is normal. And he's still working, and he's performing all his tasks. So here's a person who really doesn't meet criteria for a standard DSM-5 disorder. He doesn't have dementia. But there's clearly a lot of changes that need to be recognized. We tried to develop an approach to track this kind of symptom and name it using, without departing too much from the prior way that UDS characterizes clinical syndromes. So we've added questions to the D1 form where we can, that allow us to say that there's recent onset of symptoms. And in this case, when he doesn't meet a DSM syndrome, that's what mild behavioral impairment is for. So we've laid out the criteria for mild behavioral impairment relating to that iStart paper that Costas mentioned a few moments ago, and we allow you to designate the specific kind of categories of syndromes that relate to these behavioral changes. So in this case, for example, here's, excerpts from the DSM form. You might say that, similar to what we've said in the past, he doesn't have normal behavior and cognition. There are some changes, but he doesn't meet criteria for dementia. And in this case, he doesn't meet criteria for MCI. But the MBI criteria indicate that whatever you're seeing can't be explained by a syndrome that would be recognized in the DSM. In this case, we decided he fits that, and we indicated that he has changes in motivation, impulse control, social inappropriateness. We could discuss whether each of these things is something we agree with, but let's say we did that. And then on the B9 form, we could use that B9 form to indicate the specific symptoms that led to our conclusions about that and their ages of onset. So that's one example. And take a second example. This is a 60-year-old man who works as a college professor, and in the last 18 months, he's had a lot of cognitive changes. Again, not too far from somebody I've seen in the last year or two. So he suddenly sort of decided he wanted to start 5 businesses at once, including a combined ice cream store and a clothing store and a rideshare company. And he says, it's kind of like Uber, but it's way better than that. And a high-end Italian restaurant. He has no experience really doing any of these things. He's stayed up in the middle of the night with writing business plans, used family savings to start, investing in these things without really even discussing it with his family. He says he feels great, better than he's ever felt in years. He thinks he's so good at this. He realizes, he's the one, whatever he means by that, and that takes some discussion. He gets angry with people when they tell him to slow down. And then a few months ago, he went down to the mall and started harassing one of the developers to lease him space. And the police were called because he was so agitated, got into a fight. He ended up getting admitted to a hospital, treated with lithium and other approaches. And he improved over a few weeks. And now all those symptoms are gone. He feels back to his normal self and back at work. He's doing well. So here is someone who, the syndrome is much more recognizable as something we would see in DSM. By the way, he has normal cognitive testing. We could say this is bipolar, but of course it's notable that, it came quite late in life, which is unusual for bipolar disorder. We don't want to ignore that. So in this case, he's not MBI. He has a DSM criteria. We have to deal with that. So we also worked on the form so that we could record that thing. So in this case, the same set of initial questions would be filled out. There's something wrong. It's not dementia or MCI. Now, he doesn't meet criteria for MBI because there is a DSM-5 disorder, we think. Yeah, I can go back. So on the bottom right, you see there's a little checkbox that says behaviorally impaired, not MBI. And we do the same thing in cognitive where we say cognitively impaired, not MCI. So this is analogous to that checkbox. And so in this case, we would use that. And we indicate in the instructions that that's good for DSM-5 disorders. And then you could go to B9 again and say what symptoms you're talking about and the age of onset. And in this case, we can endorse the bipolar disorder as the primary etiology for this set of symptoms that we've recognized. And the last case is much more straightforward, and we see this a lot too. A 7-year-old man who has depression since early adulthood, on and off over the years. He's had several bouts with one hospitalization. Currently, he's been depressed for the last couple of years. He's working on his symptoms with his psychiatrist and a therapist with some resolution, but it's been difficult to treat so far. So he still feels symptoms. He doesn't have any cognitive complaints. So now here, same set of initial questions. He doesn't have MBI. It's a long-standing psychiatric disorder that explains his current symptomatology. And in this case, we would just indicate again the major depressive disorder, in this case being treated. And here on B9, we don't, the way we laid it out, we don't want you putting any symptoms there because B9 is meant for the emergence of these new symptoms that are part of the current syndrome, not longstanding, and therefore could represent the emergence of a new disorder. And that's it. Additional points that I'm making is, of course, we'll continue to use the NPIQ and the GDS, which would be filled out in parallel. Another thing that's been used a lot in the MBI and neuropsychiatric symptomatology domain is the mild behavioral impairment checklist, and we included that as something optional. It's very useful if people want to have a continuous measure that relates to MBI that you could use for that purpose, and there are thresholds that one could use if you wanted to define MBI that way, but we felt like the other parts of the form, we wanted to mandate, really go with clinical judgment as the final arbiter of this is present or it's not. So I just want to thank the whole clinical task force for working with us on this, and particularly the members of the task force. The top 5 are the ones who initially were involved, but we drew in other members like Jeff Burns and Suzanne Schindler to help us with the form. So thanks very much to everyone.
Thank you. And we are running a little long, so we're going to do 5 minutes of questions. So feel free to come up to the mic or submit them virtually.
I see someone getting up, but I'm not sure what direction they're going. Oh. No questions? Phew.
All right.
Oh, Victor?
Oh.
Could you use the microphone so people on
I guess seething anger that makes you unable to say anything is not a question.
Well, no seething anger here. Great presentation, great work. You went through some of these things pretty quickly. And the second example is someone who had a bipolar disorder. Was the option there to say meets DSM criteria for bipolar? And my follow-up question is, a lot of us aren't psychiatrists. We know that, we think we know what we recognize, but there's actually formal checklists and a lot of nuances to some of these diagnoses. Are we expected to do that, or is there something that would sort of indicate there's something going on and we think it's a DSM disorder, but we don't know for sure?
I think that's a great question, Victor. Both are. Yes, that would be the idea is that you would say he meets criteria, that we use this not MBI, not behavioral, but behavioral impaired as a catch-all for that. And then using D1, you would be able to say, in this case, it's because he meets criteria for bipolar. In terms of the second, did you want to follow up on that?
Well, but you don't always know whether someone meets criteria for bipolar unless you go back and pull the DSM-5
Right.
and sort of go through that. And
that's the second part of your question.
Yeah.
And it's really a great question. It's very important. And we sort of debated the idea of whether we could endorse or advocate for some sort of more gut feeling based approach to this, but it also became untenable. I think, when you look at the DSM, these disorders are listed there. It doesn't say you feel like they have depression. It says depression, major depression. Bipolar disorder is already on there, and so are other syndromes. And so we felt like we didn't really know what the prior implication is, but if it wasn't that it would be diagnosed, according to DSM criteria, we didn't know what it was. And so in the end, we felt like, that people we understand that, like all clinical judgments, there's going to be some variability in how, assiduously people adhere to the way to do it, but we felt like we had to sort of point to the DSM as the gold standard for how you make that clinical determination. And I guess, so that's how we thought about it, and acknowledging that we thought a lot about what you're saying, which is both of our expertise and the realities of clinical assessment.
Could I just add something?
Costas? Yeah.
Yeah, can you hear me? Yeah, I mean, I think this is a tough call, but this illustrates the the challenge that we have. These conditions are very common in this population. And I think if we're going to be rigorous as scientists, we need to measure them properly. So one of the challenges that we saw in thinking this through, it's very frequent that someone is sad and they're given a diagnosis of a depressive disorder. That's not consistent with the way we think of things. So I think I would advocate that this will strengthen the ability of the ADRCs to quantify clinically what's going on. So yes, dust off your DSMs would be my recommendation, but it's also not that difficult for the more common conditions.
I'll just to finish that line of, that last point that Costas made is there are common conditions where it's not so bad and we see them a lot and not as difficult. And one of the things that I'll point out, Alan, that's part of the clinical task force is, we've got to revise the instructions and standard operating procedures related to all these forms. And as is there now, we can introduce some, kind of bulleted criteria to make it easier for all the syndromes that we're pointing at, including some of these more common DSM-based diagnoses to help make that easier, Victor. Go ahead, Allison.
So Allison Rosen from Stanford. I'm so glad you're doing this because I'm very interested in this. And you probably want psychiatric referrals on hand to manage it if it's suddenly discovered. And that's where you can get treatment and good diagnosis at the same time. I also wanted to mention that Zahur Ismail has a version of it that we started out using it, that it can be self-administered as well as instead of informant administered, which is handy for those people who are living alone, which is very common in our veterans. So,
Great.
yeah.
Nina?
Thank you for doing this. I think it is really important to add to what we're doing at the centers, critically important. Regarding maybe tough diagnoses, I think the CTF may not have realized what they signed up for, but the previous iteration of the CTF would actually answer those type of questions occasionally. I mean, not, 7% or per day or something, but if there was a tough situation that would come up and they weren't sure, folks somewhere weren't sure what to do, Sandy can attest to this, that questions could be posed to the CTF to help adjudicate where there were tough questions. So we may give this group a break because they've done so much work and have a little turnover in the CTF at some point, but that is one of the functions that the CTF had done previously. So maybe that could be a way. We could see how often the questions come up and which ones they are, and have, FAQs and things like that to help in more common but difficult situations.
And we're going to develop some training capabilities, as I recall, some videos that might help. But I also volunteer Howie to answer all your questions.
Yeah, right. Psychiatrist extraordinaire. All right, well, thank you.
Thank you, Al.
Great job. The CTF has also envisioned that UDS4 is going to be a sort of a living process, right? We're all going to learn once it gets implemented, and we can always amend instructions and do additional training, things like that. So again, we're going to be critically dependent on everybody's feedback as we launch and move forward. So thank you again, Howie and Costas, for all the work and the rest of the subcommittee. Now I want to introduce Andy Sakin and Lisa Barnes, two individuals who don't need introduction. They are co-leading our cognitive measures work group, and they have also been leading another subgroup to discuss the issue of subjective cognitive decline. So.
Good morning. So Andy and I want to spend our time talking about the subjective cognitive decline. But before we get into that, I wanted to give an update on the cognitive battery for UDS4, because I realize that we, as the clinical task force, talk about this all the time, but you all probably aren't thinking about it as often. So just as a reminder, the consensus or the decision was that we would continue with the UDS-3 cognitive battery because we wanted to, maintain the longitudinal data that we've been collecting, but we have made a few little tweaks to it. One thing is we've added a word list memory test because you might recall that we did not have that. We only had story recall. And because, memory is so important for what we do, we wanted to add that. We did a survey of all the centers, and the most commonly used word lists were the Ray and SARAD. There were others being used, but there were, far fewer. These really outnumbered the others that were being used. So we decided, with feedback from you all, to have you all do either the Ray or the SARAD. So those centers who are already doing the Ray, you can continue. Those doing the SARAD, please continue. Those who are not doing it, we are asking very warmly that you consider doing one of those tests. And we've also decided that we need to add a recognition test. So currently we have sent a survey out to all the clinical core leaders to send in the recognition test, the list, the actual words that you're using so we can see what's out there and select the best one. We're also working on test order since we've now added this word list. So we'll have to probably change the order of the current UDS battery, and we have a small working group working on that right now. The other thing is we have decided to do the digital speech capture. So we're asking everyone to just record their cognitive testing. And we have completed a manual of instructions with details about recording and storage, thanks to Andy's team, Hannah Kraft, and the team at Boston University led by Rhoda. And we have details for sending the audio files to NAC. That'll be forthcoming. Right now, we're just asking that you record and store it. And then lastly, the video cog validation study is underway at Wake Forest, and you'll probably be hearing more about that as their data come in. So I'll turn it over to Andy now to kick off the SCD.
Morning, everybody. Back over the summer, we did a whole session on subjective cognitive decline and cognitive concern assessment. So I won't go through the scientific rationale again, but just kind of give you an update on where we are with recommended measures. The CTF cognitive group and pulling in others as consultants spent a lot of time kind of going through the various options on this. And as part of the principle of being very limited in terms of extra burden, we basically came up with 3 questions for subjective memory concerns. And they're shown here. The first one has been widely used in both epi and also in clinical studies, a number of them led by Frank Jessen. But the original item came from a paper by Geerlings in '99, and it's basically, do you feel like your memory's becoming worse? And then there's 3 choices. There's no, there's yes, and it does not worry me, and then there's yes, it worries me. And a number of different studies have shown that the worry factor is actually correlated with longitudinal outcome for risk of progression and conversion. The next 2 items come from studies that were done at Rush, and these have been studied in diverse populations, which was a really important principle for everything that we did in the cognitive group. So these are how often do you have trouble remembering things? And you can see the choices there, but basically from a gradation of not at all the way to often. And then compared to 10 years ago, how would you rate your memory? And it can be everything from much better to much worse. And there is a quantitative cut point that's been used by the Rush group that has some validity behind it that one could apply. The references are all here, and of course these materials will all be available. In addition, there was a lot of discussion when we presented this, and since that, well, what about other domains than memory? What about people that are studying FTLD or other disorders that may present differently? We certainly agree that's very important. And although not required, we recommend the choice of one of two scales. And like the principle that Lisa just articulated with the frequency of use in the centers already, the two scales for reporting subjective cognitive concerns and also for capturing co-participant or study partner ratings are the Everyday Cognition, or ECOG, and the Cognitive Change Index, or CCI. There were a few other scales used in some centers, but again, these are the two that were by far most frequent. They're short and they're optional. The ECOG has 39 items and runs about 8 to 10 minutes, probably faster for a completely unimpaired individual. The CCI has 20 items and is about 4 to 5 minutes. Both cover additional domains, especially executive and language, in addition to only episodic memory-related concerns. The ECOG also includes some visual spatial items for centers that are particularly concerned with other forms of dementia, including PCA. So those are our recommendations. It's pretty straightforward. There's not much change. Many of you are familiar with these instruments already, but just very briefly. So the ECOG, again, it's 39 items. You can see groupings of memory and language items. There's also several different executive subdomains for planning, organization, divided attention, and then, as I mentioned, visual and perceptual abilities. The CCI focuses on primarily on memory with 12 of the items, 5 executive and 3 language items that are shown here. And both of them use Likert scales. They're a little bit different. One notable difference is the ECOG focuses on 10 years and the CCI focuses on compared to 5 years. There's a lot of discussion in the field about what's the optimal time frame. Is it 1 or 2 years or 3 years, 5, 10, best ever in one's life, and so on. But most of them correlate with each other. There are some very large-scale, both epidemiologic and clinical studies going on trying to ascertain SCD-related concerns. And Laura Rabin and others are leading some of these major efforts that have over 20,000 observations within them from multiple studies around the world. I think there are going to be new options with advanced psychometrics on all the items aggregated from these very large-scale studies coming in the future. But these are what we thought was a practical approach to handling this for the UDS-4. For those interested in some of the references in more detail, the slides are posted from the earlier, more detailed presentation as well, or feel free to reach out. And with that, basically this is the CTF cognitive work group, and also especially noting Laura Rabin and Shannon Rissecher, who presented data and in Shannon's case performed specific analyses at the request of the committee to look at the relationship to amyloid tau, MRI biomarkers, and so on for various items. And Laura Rabin is leading a lot of those large-scale psychometric analyses, and she presented some pre-publication data to us as well, so we're appreciative. Anyway, thanks to the whole committee, and I think we have a few minutes for questions related to really either the cognitive battery status or the subjective cognitive concerns related issue.
Clap for us.
We've got about 15 minutes for questions.
Well, may hurry.
I just want to comment on what a great job this was. I mean, you had the amount of effort, and the other comment that has already been made, but I want to reiterate is the NAC group were incredible. The kind of support we got for organizing meetings and for it was really important. I just wondered, and because I don't recall this, did we make a decision about when the subjective complaint would be administered? Is it to individuals in follow-up who are known to not have a memory impairment? I mean, that was the one issue that we haven't really, I'm not sure we've articulated. It makes sense. And the same thing with well, the MBI diagnosis was nicely laid out so that once they're demented, we're not doing the MBI diagnosis, right? So because each of these things does add, as we've heard, some further evaluation. So we want to know where it's going to be.
So we haven't really made a final decision on this, and certainly the committee and the community can weigh in. But I would say the three questions that are part of the UDS-4, we basically should have people respond to. But whoever's analyzing the data can take into consideration the diagnosis at that visit and the staging. There are many studies that are looking at the ECOG and CCI longitudinally, tracking them with biomarkers, and there's a lot of interesting results that are either published, or I know of a number of things that are pending. So I think if someone is capable of understanding the instrument, then I think having those data points are actually really valuable, but it wouldn't be mandatory.
Yeah, and I think we did add it to the study partner form too. So both the participant and the study partner get it.
Right, so the partner, co-participant could certainly complete it if the participant couldn't.
Chad Murchison, UAB Exploratory ADRC. Two questions. So as we're starting to collect subjective information, has there been any discussion about how this may modify the D1, specifically in terms of adding transitional as a consideration when we try to look at the intersection between subjective complaints and objective representation? Because we think about NIAAA criteria and the numeric staging, for example, and they lay out very clearly defined definitions for what transitional is going to be, and it's going to be these complaints that are subjective, but no presentation of actual decline. And I'm just wondering, is there any thought to kind of like rule this in, or is it just going to be something that we kind of need to infer as we look at the data?
Well, I'd say implicit in what you're asking about in terms of that transition is really the issue of would we classify someone as having subjective cognitive decline versus MCI, which would be a defined impairment. And, the committee did discuss that issue quite a bit, and in the end thought, well, this is a continuum. There really isn't any gold standard for exactly what constitutes a significant cognitive concern. There are cut points that have been, used in various studies, some of our own and many other ones, but there's really no point yet where there's, I think, enough data to say that, well, this is exactly the burden of cognitive concerns that would be predictive of a certain outcome or certain biomarker correlation. So I think the decision was to basically leave this information, and then individual centers could use that information in the way that meets their needs for particular studies. Does that get...
It does. It really does. Again, the thought was just kind of cross-form considerations more than anything else. And actually that feeds nicely to my other question, which is one of the C2 forms that has always kind of struck me as odd is question 13, which is the one that specifically asks, based off of some sort of clinician's evaluation, how many neuropsychological tests are actually like impaired. And it seems kind of odd to have a form that is largely filled out by raters and research administrators and those folks, and then have this very clinician-focused question. And I understand the contextual rationale for this, but I'm just kind of wondering, will it kind of continue to have a home here, because that really does kind of inform a lot of these diagnoses. And in addition, one of the big things that we've talked about throughout the entire meeting has been the consideration of normative values and whether or not these are really going to be appropriate for some of our underrepresented groups and things like that. Has the CTF had any discussions about helping guide centers and clinicians on what they should be doing to actually quantify these number of tests?
So for your first point, we did have someone ask about that. So I think on that form, it asked how many domains are impaired, right?
It's the one that asks, like, based off of the clinician's evaluation, what is their performance, like, better than age, normal for age, and then,
Yeah,
like 1
yeah.
to 2, and so on.
So that's meant to be a clinician judgment.
Right.
So not the rater.
Right,
who-
right.
Who did the
Yeah.
test. But for your other question about, the diversity issue, we did look at the data that we're currently collecting in NAC across race and ethnicity, and actually, the tests are performing quite well for these diverse groups. We're seeing level differences, which we often see. And we haven't talked about, trying to figure out norms for that. But when you look at change over time, we're not seeing any differences in change over time. So again, that suggests that it really is something about the test, maybe education or quality of education, that makes the level differences. So we'll continue to talk about that in the committee, but for now, we think the tests are appropriate as being used in these diverse communities.
Because again, the relative change within an individual is really going to be the most important aspect. so-
Exactly.
And as long as that's stable, like, I'm certainly content, so thank you.
Thank you.
I'm Krista Mulder from Washington University in St. Louis. I just want to comment on Dr. Barnes' first slide, which is that our IAB has determined that just recordings of voice by themselves are an identifier. So just thinking in terms of the security and the data upload for those files, I just wanted to throw that out there because even if they don't say their name or dates or anything, just the voice itself.
This is certainly a consideration. I imagine Rhoda is probably here somewhere who's been leading these efforts. But all of those kinds of, regulatory IRB issues will have to be addressed. And various solutions have been proposed. There's definitely a plan for editing out any protected information. But the voice signature itself is more of a challenge. And various solutions have been talked about for maybe having an enclave where analyses could be performed or other strategies. I don't know if Rhoda's here and might want to comment on that.
I don't see her.
But we're certainly aware of the issue, and there will have to be a solution for that. Thanks, Krista.
Jeff Kay, Oregon, ADRC. Well, I'm going to follow up on what you were just saying. There's other kinds of data like GPS data, and it also has to have this extra level of consideration. What I did want to ask about is, we're appropriately trying to shore up things that we haven't been doing or things that the field has evolved to. But one of the things that can affect and just create more noise is the ordering of when these different scales or queries are given and who is answering them. So if you're asked about your subjective opinion about your cognitive function right after you have your cognitive testing, you're going to get a different answer than if you're just doing it online. And then who is is it the some of these are self-report. There are, and you're hearing, oh well, there's self-completed and then informant completed, but you could do either one. And so I think that we have to be careful about. It creates another burden of trying to record even those sort of meta aspects of the whole assessment. But I think you need to keep that in mind because it really can affect the data across all of these scales.
Thank you, Jeff. I think that's a really great point, especially for the subjective ratings. With the move toward electronic data capture, hopefully there's a timestamp, so at least that factor could be looked at. We've tried to be flexible in terms of order of administration and the way the exam's done because there are center-to-center differences. But at a bare minimum, capturing that information so it could be looked at, I think would be really valuable.
I think we added it to Form A2.
I think that's right.
Right,
Yeah.
so it is separate from the COG, but that's a really good point. That's it. Yay, thank you.
Thanks for the questions.